Hello all, myself Anjali Kotian, Assistant Professor in the Unit of Respiratory Therapy at Yenepoya School of Allied Health Science. Today we'll learn about mechanical ventilation in neonates. At the end of this session, you will be able to understand the following objectives. Explain the indications and contraindications of invasive mechanical ventilation in newborns. Differentiate between various types and modes of mechanical ventilation. Evaluate the effectiveness of current ventilator settings in improving oxygenation and ventilation. And understand how to formulate decisions on weaning and extubation. Mechanical ventilation in neonates is a critical aspect of neonatal intensive care, primarily used to support infants with respiratory distress or failure. Now, when I talk about mechanical ventilation in neonates per se, it is not how we ventilate an adult. Ventilating an adult is far more easier because the respiratory system development is completed. Whereas in neonates, the respiratory system development is still going on and their lungs are very compliant and they are also at risk of getting injured. That is, lung injury is at the primemost risk here. This life-saving intervention involves the use of mechanical ventilators to assist or replace spontaneous breathing, ensuring adequate gas exchange and maintaining oxygenation and ventilation in vulnerable newborns. Whenever I say mechanically ventilating a neonate, it is about how we understand the aspects of oxygenating, ventilating and then also making sure that we prevent any kind of lung injury that can happen to that neonate. So when we talk about ventilating a neonate, it is more like lung protective ventilation that we follow. So what are the indications or when do we actually think about a baby requires invasive mechanical support? So here are certain categories where I have defined how and when we can make sure the baby is going into invasive mechanical ventilation. Inadequate or absent respiratory efforts, that is either the baby is having absent, weak or just intermittent spontaneous efforts, or there are chances of apnea, the baby is having recurrent apnea, so as frequent as more than 6 apneic episodes per hour, that will come under or severe apnea category. So in such cases, having an invasive mechanical support for the baby is more important. When the baby's work of breathing is excessive, that means you can see visible signs of respiratory distress, that is marked retractions, severe tachypnea, that is usually more than 100 breaths per minute. If the baby is having higher oxygen requirement, now this could be either the baby is on high flow nasal cannula or a non-invasive support, mechanical ventilation support, whereas the baby is requiring higher FiO2, or if you are suspecting persistent pulmonary hypertension of the newborn, then we say the baby definitely requires invasive mechanical ventilation. Apart from this, if the baby is having severe respiratory acidosis, that is from day 0, that is from the day of the birth of the baby up till day 3 of life, if the pH is less than 6.5, or after day 3 of the life, if the pH is less than 7.0, then we categorize it as severe respiratory acidosis and that mandates the requirement of invasive mechanical ventilation. If there is moderate or severe respiratory distress, like I said, if you see obvious signs of respiratory distress in the baby, it could be either grunting, could be retractions, or could be tachypnea, cyanosis, then you definitely know that you have to go for invasive mechanical ventilation. Or if there are contraindications for non-invasive support. Now usually when we ventilate a baby, the first line of ventilating a baby would be non-invasive ventilation. But in such cases, there are few conditions where we cannot go with non-invasive mechanical ventilation. We have to go with invasive mode of mechanical ventilation only. What are those cases? Cases such as intestinal obstruction, intestinal perforation, recent gastrointestinal surgery, or congenital diaphragmatic hernia, that is also called as CDH. These are the conditions where we cannot give non-invasive ventilation to the baby. We have to directly intubate the baby and then post surgery we can extubate and then think of non-invasive ventilation. Apart from this, any post-operative period where the baby has come after a surgery, there is residual effect of the anesthetic agent, or the baby still requires some muscle relaxation, in such cases we go for invasive mechanical ventilation. Coming to the modes of ventilation, when we talk of modes of ventilation per se in neonates, there are three primary modes of ventilation that we use, that is the assist control mode, SIMV mode, and pressure support ventilation. So assist control is also known as patient triggered ventilation. In majority of the ventilators that are available to ventilate a neonate or a pediatric, assist control mode will be known as patient triggered ventilation also. So what is this assist control mode? It is a mode that allows the patient to control the ventilator rate but provides a minimum number of inflations in case of inadequate or absent respiratory effort. So what this ideally tells us, the baby can breathe in this mode of ventilation and the ventilator is only going to assist the patient's breaths. If the baby does not take a breath, the ventilator will give a full mandatory breath. So in such conditions, what happens is, this becomes our mode of choice. Whenever we think of starting or initiating mechanical ventilation for babies, we always go ahead with assist control, or what you know as patient triggered ventilation. So what happens in patient triggered ventilation is, you will set a minimum number of respiratory rate, or maybe 10 breaths per minute. If you have set 10 breaths per minute and the baby is breathing at somewhere 15 breaths per minute, then those extra 5 breaths will also be supported by the ventilator. So that is what makes assist control mode of ventilation the choice of mode to initiate mechanical ventilation in babies. Coming to SIMV, it is nothing but synchronized intermittent mandatory ventilation. It provides a preset number of inflations as in standard IMV, but these are synchronized with the infant's spontaneous respiratory effort. Now, if the spontaneous breaths are present in excess of the set ventilator rate, they won't be supported. They will be completely spontaneous. So, how I can put it in terms of clinical application is, if, like for example, you are setting a respiratory rate of 10 breaths per minute in SIMV, only for those 10 breaths the ventilator will give support. If the baby is breathing 5 extra breaths, if baby is taking 5 extra breaths, those 5 breaths will not be supported and they will be completely spontaneous. And that is why SIMV mode is one such mode that will help you from transition from initial stabilization of the baby to going up till weaning. So SIMV is that mode of ventilation in neonates that will help you in weaning by giving some burden to the baby so that the baby can take few breaths completely spontaneous. PSV. PSV is pressure support ventilation. It is a flow cycled and pressure controlled continuous spontaneous ventilation mode that supports every spontaneous breath just like assist control, with the only difference being flow cycling. In PSV, what happens is, every breath will be supported, but only thing is, it won't be mechanically supported. It will just be given a slight support will be given to the baby. Rest all of the work is done by the baby itself. So per se, this is a completely spontaneous mode where all of the burden is put on the baby and the ventilator is just pushing the baby to breathe better. So here what is the primary setting that we keep is pressure support and P. So if you can see in the graph there, you can see I have mentioned PTV followed by SIMV followed by PSV. So usually when we mechanically ventilate a neonate, first mode of choice, like I told, would be patient triggered ventilation, followed by when I am planning for weaning or when I think, okay, I need to check whether the baby is ready to be extubated or not, I will go for SIMV, and then I will put the baby on PSV, that is a spontaneous mode, and we'll see if the baby can maintain for 30 minutes or more. Now, it's not necessary that you go step by step, that you go from PTV to SIMV and then PSV. You can directly go from patient triggered ventilation to pressure support ventilation also. So this is how usually we ventilate neonates in the NICU. Talking about the key parameters in mechanical ventilation, whenever we talk about the ventilator, there are certain things that we should know. There are certain terminologies that you should be familiar with, and those are as follows. First is the tidal volume. Tidal volume is the amount of air delivered to the lungs with each ventilator breath. Now for babies, what we target is somewhere between 4 to 6 ml per kg of tidal volume. Peak inspiratory pressure, that is PIP. So setting peak inspiratory pressure is guided by a visual appreciation of a just adequate chest rise, audible breath sound, and preferably the measured exhaled tidal volume. So the peak inspiratory pressure is the pressure or the highest pressure that is required to make sure that all of the tidal volume reaches the baby's lung. Okay. So how you will get to know whether whatever PIP you have set is fine or not is, like I said, you will see an adequate chest rise, you should be able to hear audible breath sounds, and the measured exhaled tidal volume should be preferable. That means what I said, the baby should have between 4 to 6 ml per kg. So the exhaled tidal volume should be somewhere near to that value. The respiratory rate, that is nothing but the number of breaths delivered by the ventilator per minute. Positive and expiratory pressure, that is the pressure maintained in the lungs at the end of expiration to keep alveoli open. Now PEEP is one important factor when we are ventilating neonates, because with mechanical ventilation there is a phase of inspiration and there is a phase of expiration. So every time the alveoli, they have pressure going inside them, and then the exhalation is passive, that is automatically exhalation happens. With every inspiration and expiration, there is a chance that the alveoli will open and close automatically. So when this repeated opening and closing happens, there is a chance the alveoli will get injured, and you can have something known as atelectotrauma or alveolar injury. To prevent this, what we do is we set PEEP, that is the positive and expiratory pressure. PEEP is that pressure that at end of expiration it remains in the alveoli, thus making sure that the alveoli remains open at least to some extent and it does not close completely. So in babies we go for a PEEP of between 5 to 8 centimeters of water. If they have conditions like respiratory distress syndrome, we go for higher PEEP. FiO2, that is the fraction of inspired oxygen. It is the concentration of oxygen that is delivered to the neonate. Now FiO2 is a very debatable setting or parameter, I would say, because it depends on the baby's condition and the baby's oxygen saturation, what you are targeting. Different disease conditions will require different FiO2 requirement, and also the only parameter that you will depend on is the oxygen saturation of the baby. For preterms you will target somewhere between 92 to 95%, and for term babies you can target 95% to 98% of oxygen saturation. If you can maintain this oxygen saturation, and FiO2 between 40 to 60% is more than enough. But in certain cases where the baby requires higher oxygen, you can go up to 60 to 100% of FiO2. Talking about the inspiratory time, this is one such setting that we get to manipulate in the ventilator. So it is the timing of the inspiratory phase of the ventilator cycle. So if I talk about TI, it is usually between 0.4 to 0.6 seconds. So if you want to maintain an I:E ratio of 1:2, then you have to make sure that your inspiratory time is somewhere between 0.4 to 0.6 seconds. Anything below 0.4 will decrease the tidal volume that is being delivered, and anything above that 0.6 seconds will hamper your expiratory time. So here is a graph that will help you tell how to oxygenate and ventilate a baby. So when I talk about ventilating a neonate, it is about the CO2 elimination, that is our prime problem. Carbon dioxide retention will be there, how to wash it out. Now your carbon dioxide, whatever is being formed in the lungs, if adequately it is not getting eliminated, we have to do certain changes in the ventilator so that you can cause CO2 elimination. Now your CO2 primarily depends on minute ventilation. But minute ventilation is not something that we can control directly, because minute ventilation depends on your frequency and tidal volume. So what you can do is you can manage the frequency and the tidal volume of the baby so that you can achieve targeted minute ventilation, and by achieving the targeted minute ventilation you can make sure appropriate CO2 elimination happens. So when I talk about frequency and tidal volume, frequency can be further monitored by the expiratory time and IS/E ratio. So what I mean by this is, every time you don't have to touch the respiratory rate or manipulate the respiratory rate, you can also go ahead and change the expiratory time, or you can also change the IS/E ratio. When I talk about tidal volume, if you are using volume control mode of ventilation, definitely you can directly go and manipulate the volume control setting. But if you are using pressure control mode of ventilation, then you have further two more parameters. There will be the end expiratory volume. How much end expiratory volume are you targeting, and what is the peak inspiratory pressure that you have set. So the peak inspiratory pressure, like I told you, is a pressure you are setting so that this much amount of tidal volume can be delivered to the baby. So this peak inspiratory pressure will vary somewhere between 12 centimeters of water to 18 centimeters of water. Again, it will change from disease condition to disease condition. Conditions with more resistance will require higher PIP compared to conditions with lesser lung resistance. Talking about oxygenation. Now when I talk about oxygenation, FiO2 is one such parameter that is directly going to change how your oxygenation happens. So the moment you change the FiO2, definitely there will be some change in the oxygen saturation. But there is one more parameter, that is the mean airway pressure. If you can target a good mean airway pressure, then you know that the baby can be oxygenated well. But this mean airway pressure is not a direct parameter that you can control. How you can control this is by the peak inspiratory pressure, the PEEP, the IS/E ratio and the flow. If you can manipulate these four settings very easily, you can maintain a mean airway pressure. Now please remember, the mean airway pressure should not be on the higher end. It should be always maintained on the lower end, somewhere between 8 to 10. Because if you go at 12 centimeters of water or 14 centimeters of water, what will happen is the baby, it will indicate that the baby's requirement for oxygen is higher, and that will need you to use advanced methods of oxygenation like ECMO or high frequency oscillatory ventilation. So this is a table that shows you the various settings. Now all of these parameters have different settings, but it does not vary with each mode. With every mode of ventilation, the setting that you do is going to be common. So if I talk about the tidal volume, it will be somewhere 4 to 6 ml per kg. The peak inspiratory pressure will be somewhere 12 to 18 centimeters of water, but again, depending on the disease condition, you can change it. You can go for higher peak inspiratory pressure. We can always go up to 22 centimeters of water also, depending on the condition. The positive and expiratory pressure, somewhere between 5 to 10 centimeters of water. Again, depending on the condition, you can adjust the PEEP. Respiratory rate is ideally between 35 to 50 breaths per minute, but in cases of CO2 elimination, if you have to change the respiratory rate, you can go for a higher respiratory rate, that is 55 or up till 60 breaths per minute. FiO2 ideal setting is between 40 to 60%, but if the baby requires higher FiO2, there is a demand for higher oxygenation, then you can go between 60 to 100% as well. The inspiratory time, it should be between 0.4 to 0.6 seconds, and the flow should be somewhere between 3 to 15 liter per minute. Now flow is one such parameter that we usually do not set in adult ventilators, but when it comes to neonate, depending whether it is a term baby or a preterm baby, we are going to change the flow. So flow for term babies can be somewhere around 10 to 15 liters, and for preterm babies it can range somewhere from 5 to 8 liters per minute, and if they are very preterm you can go as low as 3 liter per minute. So the flow can be adjusted also depending upon what is the age of the baby. Is it a preterm baby or a term baby? So now that we have seen what are the modes of ventilation, what are the parameters and what are the settings that is used for initiating mechanical ventilation, we will look at what are the problems that we face when we are ventilating the baby. So the primemost problem that we would see is elevated PaCO2. Now what needs to be done when you see an elevated PaCO2 in an ABG, or if you see the capnography levels are on the higher side? So the first most thing is verify the ET tube position and the patency. Make sure the ET is in place, because these are cuffless endotracheal tubes that we use for babies. There is a higher chance that the tube might get displaced or malpositioned. In such a case, check the ET position, verify the ABG, make sure it is an arterial blood gas. Very often there is a tendency to take a venous blood gas because we don't want to prick the babies again and again. So in such cases, verify whether it is a purely arterial blood gas, whether it is a mixed sample or a venous blood gas. If it is a venous blood gas, check whether the carbon dioxide levels are similar or not. If it is still higher for a venous blood gas, that means the PaCO2 is definitely higher. Transilluminate and rule out pneumothorax and get a chest X-ray done. Usually elevated PaCO2 will also be seen with pneumothorax that is present. Now pneumothorax is one such complication of mechanical ventilation. When we ventilate the babies, I told you they have compliant chest wall. So what will happen is there is a higher tendency to have pneumothorax with high pressures. So if you are using high pressures for some case, definitely there is a risk of pneumothorax. The easiest thing to do is transilluminate. Use illumination, transillumination, and then you can verify if there is a pneumothorax. If not, get a chest X-ray done just to rule out pneumothorax. Apart from this, what else you can do is decrease the inspirated time by 0.1 second decrements until you get an I/E ratio of either 1:2 or 1:1.5. Reduce the PEEP. If the lungs are hyperventilated and if your PEEP is on the higher end, there is a chance that appropriately ventilation will not happen. Carbon dioxide retention will be there. So in such cases you can see if the PEEP can be reduced if it is not required by the condition. Increase the rate further in either 5 to 10 breaths per minute increment as required. So when I say increase the respiratory rate, it is not like the respiratory rate was 35, you suddenly made it to 50. No, you can do the increments at 5 breaths per minute or max to max by 10 breaths per minute increment. Okay. Increase the PIP in 2 centimeters of water increment to achieve adequate chest expansion and get a good tidal volume, exhale tidal volume. So if you notice that the peak inspiratory pressure that you have set, it is not giving adequate chest rise, then you will have to think about increasing the PIP by 2 centimeters of water increment. So per se, if it was 14 centimeters of water, you can go for 16. Even with 16, if you don't get a good chest rise, go for 18 and then so on. Consider muscle relaxants, as you can also notify that the fellow attending that this is the problem that we are facing with mechanical ventilation. Now this is the last step where you have tried everything, every manipulation with the parameters of the ventilator. Even after that, if you see there is an elevated PaCO2, then you will have to definitely look on to the other causes. Similarly, we have one more problem that we very commonly face, that is the reduced PaO2, that is your arterial oxygenation. So the first step would be similar: verify the ET tube position and the patency, verify the arterial blood gas, whether it is an arterial blood gas. If it is a venous blood gas, the oxygenation is going to be usually on the lower side, but if it is too low, then you will have to think that definitely there is some issue with the baby's oxygenation. Transilluminate, rule out the pneumothorax, get a chest X-ray. Increase the FiO2 to up to between 60 to 100%. If it was on the lower side, increase the inspiratory time to 4.4 to 0.6 seconds, and you can go up to an I/A ratio of 1:1. This is in cases where your only aim is oxygenation and the ventilation is fine. If the ventilation is also having an issue, then the I/E ratio should be maintained at 1:2. Increase the positive end expiratory pressure. You can go up to 10 centimeters of water. Increase the peak inspiratory pressure. By increasing peak inspiratory pressure, what will happen is you can increase the optimal tidal volume delivery. If you can optimize the tidal volume delivery, it will help in better oxygenation. So these are certain things you can follow, and apart from this, always notify the fellow attending if there are no changes even after all these manipulations. You will have to look at the other causes of oxygenation. Maybe it is a shunting issue, maybe the baby is anemic. So if you look at all these possibilities, you can definitely tailor the approach as per this condition. Now that we have also seen how to maintain a baby while it's being ventilated, the next step is definitely weaning. So what is weaning? One thing when it comes to neonatal mechanical ventilation is we start thinking about weaning the baby and extubating the baby from the time the baby is intubated, because the babies have a higher tendency to become comfortable with the mechanical ventilator and then ultimately become ventilator dependent. So weaning in neonates refers to the process of gradually reducing and ultimately discontinuing the respiratory support once the infant demonstrates sufficient respiratory function. This is a very critical step in an ICU and requires careful consideration to avoid complications such as extubation failure, bronchopulmonary dysplasia, or prolonged ventilation. So like I told you, from the day one, we are thinking about extubating the baby. So how do we go here? Step by step, that is the rule. You always follow step by step rule in an ICU, and when you want to do changes, you have to remember it should be as follows. The PIP should be in decrements of 2 centimeters of water, FiO2 should be in decrements of 5%, and the rate should be in decrements of 5 breaths per minute. If you can follow this decremental rule 2-5-5, then definitely you can have a very smooth weaning process, thereby not placing a lot of burden on the baby and also trying to reduce the work of breathing of the baby. Please make sure that the FiO2 is somewhere between 40 to 50% before changing any of the other parameters. Reduce the PIP as clinically indicated. So if the baby's condition is getting better and you can decrease the PIP, always remember, even though you reduce the PIP, the chest rise should be adequate. If chest rise is adequate, that means your weaning is successful and it is happening gradually. Otherwise, what will happen is you will put unnecessary burden on the baby and you will end up giving the baby respiratory distress. Reduce the PIP to 10 to 14 centimeters of water just before planning extubation. Reduce the rate to almost 35 breaths per minute. If it was on the higher end, if it was 35 itself, you are good to go. Once all these parameters are on the lower end and the mean airway pressure is somewhere between 8 to 10 centimeters of water, you can know that the baby is ready to be extubated. Now just before extubation, steps may be taken such as implementing a trial on CPAP, stopping the feed, giving SBT, that is spontaneous breathing trial, which is actually optional, and changing to pressure support mode of ventilation 2 hours before the planned extubation. If you remember, when I was talking about the modes of ventilation, I told that sometimes directly from PTV, that is the patient triggered ventilation, we go to pressure support ventilation. So if your baby can maintain on pressure support mode of ventilation for somewhere 30 minutes to 2 hours, you can easily predict that the baby can be extubated and then put up on any other mode of support. Nursing care and observation of the neonate for signs of increased work of breathing are informed 30 minutes prior extubation, and finally the neonate will be extubated. So after taking all these things into consideration, you can go ahead and extubate the baby, and make sure if it is a preterm baby, please have a trial of caffeine. You can keep caffeine medications ready so that the baby can be given on caffeine administration can be done so that it does not go into apneic episodes. There are certain advanced strategies to improve oxygenation and ventilation. Even if all your manipulations on the mechanical ventilator fail and they are not giving you favorable results, or you are not still able to manage the baby's oxygenation and ventilation, these are the three modalities that we go for: advanced modalities of oxygenation and ventilation, that is inhaled nitric oxide therapy, ECMO, that is extracorporeal membrane oxygenator, and HFOV, that is high frequency oscillatory ventilation. These are the advanced strategies that we use in an NICU to improve the oxygenation and ventilation. To summarize, mechanical ventilation supports or replaces spontaneous breathing in units with respiratory distress due to conditions like respiratory distress syndrome, sepsis, or any congenital anomalies. The common modes of ventilation, like I told, are including SIMV, patient triggered ventilation, and pressure support mode of ventilation. Also high frequency ventilation, which is an advanced modality to maintain the oxygenation and ventilation. These are the modes that are used to tailor to the lung compliance and the disease that the baby is having. Ensure adequate gas exchange, that is the oxygenation and ventilation. Minimize the lung injury, that is any volutrauma and barotrauma, and facilitate early weaning to avoid complications like ventilator dependency or any injury due to mechanical ventilation complications like bronchopulmonary dysplasia. All in all, having a tailored approach to ventilate a neonate is very important, because all neonates do not show similar traits, they don't have similar lung compliance, and that is why you will have to look at how the baby is responding to the mechanical ventilation. And if the baby is responding well, start the weaning process immediately. If the baby is not responding well, always try to find out the cause, what is happening and how it can be corrected. By this you can end up actually ventilating the baby well. These are the references, and thank you.